This is Lauren Dunlap, Executive Director for Advocacy and Awareness for Autoimmune Disorders Association, or AAIDA, in Charlotte, North Carolina, and I'm so pleased to host today's webinar in partnership with the American Behcets Disease Association, or ABDA. AAIDA's mission is to create awareness, advocate, and conduct research to help the greater than 25 million Americans living with immune disorders. This is AAIDA's third of 12 educational webinars for 2021, and today I am joined by Dr. Firas Kassab, who will present Understanding the Immune System and Autoimmune Diseases. Dr. Kassab has been practicing rheumatology in the Charlotte area since 2010, and in October 2020 opened Articularis Healthcare South Charlotte Rheumatology, an independent rheumatology clinic. Dr. Kassab earned his medical degree from the University of Damascus College of Medicine and completed his internal medicine and rheumatology training at the University of Texas at Houston Health Science Center in Texas. Dr. Kassab serves as a board member and past president on the North Carolina Rheumatology Association board and is also a fellow member of the American College of Rheumatology and a member of the American Medical Association and the Independent Physicians of the Carolinas. Dr. Kassab, thank you for joining us. Please proceed with your webinar.
Hello, good evening, everyone, and thank you, Lauren, for this kind introduction. Before we start, I want to make sure that everyone can hear me. So, Lauren, is there a way to confirm that everyone can hear me fine?
Can I just get a confirmation from maybe somebody typing in a yes on the question box so that you can hear Dr. Kassab? Oh, yep, got a bunch of yeses there.
Wonderful,
Dr. Kassab.
wonderful.
Thank you so much, guys.
Yeah, speaking to myself would not be fun way to spend this evening. So I appreciate everyone taking time of their evening to be with us and listen to this interesting topic. I would like to thank the organizations that are hosting this webinar tonight and appreciate celebrating Autoimmune Disease Awareness Month with improving the understanding of these conditions. As Lauren mentioned, I've been a rheumatologist for about 14 years, and the last 10 of which have been here in Charlotte, and was fortunate in the past 6 months to open my own practice in collaboration with Articularis Healthcare Group, the biggest independent rheumatology group in the US. And, you know, through my career, as a rheumatologist and as I diagnose patients with autoimmune conditions, the first question that many patients ask usually is, why did this happen to me? And this leads to a long conversation about autoimmune diseases. So I decided to make the objective of this talk is to dig a little bit deeper to talk about the immune system and about how it functions, and how do autoimmune diseases happen and why they happen, or at least why we think they happen at this point. These details are not cannot be done during a visit with a patient, so I hope that some of the patients will find this useful. And although the title is Understanding the Immune System and Autoimmune Diseases, the more appropriate title would probably be trying to understand the immune system and autoimmune diseases, because what we think is true right now might not be true a few years from now because of the advances in this topic. What I learned in medical school all these years ago is now considered primitive knowledge. So we always have to continue to keep up with the knowledge in this area. I do not have any financial conflict of interest to disclose for this presentation. I will not be discussing specific medications or giving advice on specific conditions. The first part of the talk will be about the discovery of the immune system, talk about a little bit of history, which I always find fascinating, and about the different elements of the immune system and how it functions, and then talking about how things can go wrong and the dysfunction of the immune system. And then we will shift gear to talk about autoimmune diseases, and how they happen. I also will discuss a very interesting theory or hypothesis about the autoimmune conditions and the allergic conditions called the hygiene or the old friends hypothesis. And then we'll finish with talking about two very common autoimmune conditions we see in rheumatology, rheumatoid arthritis and lupus. Just some quick facts on these conditions that some people might find useful. So let's start with history. And in fact, the first mention of what could be construed as the immune system dates back to 430 BC, when a plague called the Great Plague swept Athens and took a lot of the population there. And the Greek historian Thucydides mentioned this Great Plague and observed that people who survived the plague, including himself, were able to tend to the sick without worrying about getting it again. So this is the first time in history where there was mention of some form of immunity towards disease. Fast forward to the 18th century, where the French scientist Pierre-Louis Maupertuis experimented with scorpion venom on mice and dogs, and found actually that some animals were immune to the effect of the venom while others are not, indicating that there is some difference in how their bodies responded to that venom. And then in the 19th century, Louis Pasteur, another French scientist and biologist, and considered the father of vaccinations, is the one who actually started shifted the understanding of how diseases happen and started the germ theory. It was very revolutionary at that time because diseases were thought to be due to some unknown substances in the body, and no one thought that some diseases, very common diseases, can happen from these microorganisms we call now bacteria or viruses around us. In the turn of the 20th century, German physician and biologist Robert Koch proved the theory of germs by evidence and isolated actually the tuberculosis and anthrax organisms. And then he received the Nobel Prize for that discovery in 1905. And then a few years later, another German scientist was awarded the Nobel Prize for his work, including discovery of antibodies and acquired immunity. That is Paul Ehrlich. So immunity is generally a term that confers protection against a threat. However, it means different things to different people, like in the case of this student in this cartoon, who actually wanted immunity against the threat of this rather innocent-looking teacher, in my opinion. But that is what immunity is. So what is the function of the immune system? Well, the most obvious function is the defense against foreign threats, whether it's bacteria or viruses. However, one of the very important functions of the immune system is actually defending against internal threats, such as abnormal cells that could become cancerous. And one of the most fascinating functions is what is called tolerance. So tolerance is recognizing self from non-self. And this process is so important because it really determines how the immune system can deal with outside threat. If it cannot recognize what is self and what is non-self, a lot of things can go wrong. And one of the fascinating aspects of this tolerance is how pregnant women their immune system can build tolerance against the infant's cells and not attack it, even though it is considered foreign. And the key is in how the placenta separates the mother and the infant cells from each other's. So a lot of functions of the immune system. And if we want to dig a little bit deeper into this, we want to talk about what's called the innate and the adaptive immunity. So the immune system is frequently likened to the military. There are so many branches with different functions. And that's what I tell many of my patients is when they talk about the immune system, is not just one single thing. It has so many different branches. And when we give a medicine that suppresses the immune system, that doesn't mean the whole immune system is suppressed. It is frequently that only a small branch of the immune system is suppressed.
Dr. Kassab, can I just pause right quick? I just got is everybody able to see the slides? I just got a comment that if there was a slideshow that we're supposed to be following, is everybody else able to see the slides?
I shared my screen.
So Tina, I think it might be an issue with your particular screen. You might want to try a different browser if that's available, because everybody else is saying that they can see. Well, Belinda, you can't see it either. I wonder if you're on the same screen or browser. I would try. Everybody else says they can. So I think it's a browser issue, but I wanted to just clarify that right quick. If y'all, Tina and Belinda, can you maybe restart with a different browser?
And Lauren, okay, will the presentation be available with the slides later on?
Yes, this is being recorded and will be posted on the AAIDA website later this evening or tomorrow after it's done uploading. So if you did miss a slide because of a browser issue, then you will be able to review that later and within the next couple of days. Okay. Go ahead, Dr. Kassab.
Okay, you're still, I clicked something here to see if that would help. Is everyone still able to see the screen? Everyone else?
Yes, everybody else is just.
Okay, I'm sorry for those who can. We were talking about the different subtypes or the cells in the immune system. And I was mentioning the innate and adaptive immunity. So think of the innate immunity as the first line of defense against a threat. It acts very quickly within the first few hours, and it deals with the threat very quickly. However, it is not as efficient as the other type of immunity, which is called adaptive immunity, which involves more specialized cells, more specialized forces that tailor the response to the threat to be more effective and build a memory for the future so that if that threat happens again, they can deal with it much more efficiently. A threat might be a microbe, a virus, or many other different threats. So in other words, the innate immune response is threat non-specific, it is immediate, it doesn't produce any memory, it is present in very primitive species, including the species that have only one cell, and it is usually the first defense cells that perform it. Some of these cells are called macrophages. In the adaptive immune response, it is much more specific. It's like those special forces that are very trained to deal with a specific threat. It happens gradually over time. It produces memory, which is the key factor for vaccinations, in fact, and it is only available to certain species, the more advanced species, including humans and all vertebrates. And those specialized cells are typically called lymphocytes, which is a subset of the white blood cells. They're called T and B lymphocytes. So those lymphocytes are, as I said, divided into B lymphocytes and T lymphocytes. And the B cells are the ones who produce these little proteins called antibodies. And those antibodies have areas that are very specific to the surface of these proteins that we call antigens. So antigens are pieces of the foreign material, whether it's a microbe or a virus. These antibodies attack those pieces, and then by that, they can take care of the threat. The other cells are T lymphocytes, and they are like the generals in the military. They kind of activate each other, and they decide how to deal with the threat, and then they tell all the other cells around them what to do. So they go and tell other cells to go and deal with the threat or the microbe. So in a perfect world, the immune system acts either immediately for an immediate threat or over time for a more specific response, and the body is protected from all sorts of dangers. However, we certainly don't live in a perfect world, right? In a perfect world, for instance, the IRS would not exist, and we don't have to really prepare or pay our taxes. But unfortunately, that does not exist. And like other organs, the immune system can be very dysfunctional. And as in this cartoon, where some of the cells and elements of the immune system decide to go and do something wacky and overreact to something really harmless like peanut butter, and that's how allergies really start. So this might look really very complex and intimidating, but I promise I'm gonna make it very simple. I just wanted to touch base about these 4 different types of the immune system dysfunction. How do things go wrong? So the first type is called hypersensitivity reaction or hypersensitivity disorders. These are typically what happens in allergic reactions. So when an allergen or a pollen in this example, it could be peanut butter or any type of allergen, come in contact with the lining of the body. So in the case of pollen, this is maybe the lining of the nose or the sinuses. And it can activate the immune cells, one of which is this cell called the mast cell, which has all these little granules in it that contain a lot of mediators. One of the mediators is very famous, which is histamine. So what happens is the mast cell, by repeated exposure to this allergen, eventually decides that it had enough, it got enough trigger for her to release these mediators and cause all the symptoms that we are familiar with allergic reactions. These could be things like histamine or cytokines that can cause actually more prolonged reactions. Things like hives or hay fever are examples. So asthma and allergic rhinitis or typical allergies are examples of how this dysfunction of the immune system happens. And this is important because a lot of patients don't understand that allergies happen very differently from autoimmune conditions. And patients who are at risk for allergies do not necessarily have a big risk for autoimmune conditions because it's a totally different kind of a dysfunction in the immune system. The second type is an antibody-mediated disorder. So what happens is in this type is that the antibody is mistakenly produced by the immune system and goes and does something that it's not supposed to do. So in the case of Graves' disease, which is a disorder of the thyroid gland where it produces too much thyroid hormone, this antibody goes and attaches to this receptor on the thyroid cell and asks the cell to produce too much thyroid hormone. This receptor usually binds to the hormone that is produced by our brain gland to tell the thyroid how much to produce of the thyroid hormone. So that is what causes Graves' disease. An opposite situation is when the antibody, also produced mistakenly by the immune system, actually blocks the receptor. So in this condition called myasthenia gravis, which is an autoimmune neurologic condition, the antibodies in that condition will block the receptors for acetylcholine, which is an important neurotransmitter that connects the nerves to the muscles. So when this antibody is blocking the receptor, the acetylcholine cannot activate the muscle, and the patient suffers from fatigue and many other symptoms that are typical of this condition. A third type is called the immune complex type. So in this situation, those antigens that we talked about, those pieces of proteins that could be coming to the body from different sources, attached to the antibodies that the immune system produced, and then they clump together and cause these immune complexes. And then these immune complexes can go to different areas of the body and cause harm and tissue injury. So in the case of vasculitis, a condition that we treat in rheumatology, these complexes are depositing on the lining of the blood vessel and cause injury there. In the case of lupus nephritis, which is a condition where the lupus patients' kidneys get affected by the condition, those complexes can go to the kidneys and cause the problem. And then finally, the fourth type is a cell-mediated disorder. And this is one of the more common ways of the immune system dysfunction, where these T cells or the immune cells go and become overreactive and attack specific tissue in the body. So in the case of type 1 diabetes, these T cells can go and attack the insulin-producing cells in the pancreas. In the case of rheumatoid arthritis, these cells go and attack the cells lining the joints, called the synovial cells, and cause the inflammation that we see in rheumatoid arthritis. All right, so we discussed the different types of immune system dysfunction, and now let's shift gear and talk about autoimmune diseases and how do they happen. And then we'll end again by talking about rheumatoid arthritis and lupus. So the most accepted theory is that patients who have autoimmune diseases have certain genes that put them at risk for autoimmune conditions. And yes, I hear it always from patients that they want to blame their parents for what happened to them. And that is partially true, but not the whole truth, because autoimmune diseases are not passed from generation to the next. You do pass the genes that put you at risk for the condition, much like hypertension and diabetes, but you don't actually inherit the disease itself. So there's something that happened to you without the fault of your parents if you ended up with an autoimmune condition. And so these genes, what they do is that they allow some of the blood immune cells called lymphocytes to become self-reactive. So they lose their ability to tolerate what is self in the body. And that step is important, but it's not enough, because they can be harmless. They can be sitting in the lymph glands in the body and not doing anything. And that's why autoimmune diseases can happen over a long period of time, because these self-reactive cells can be sitting there and doing nothing. And then there is a trigger that comes, typically an infection of some sort, or maybe a stressful event in life that triggers these self-reactive cells and become a much bigger self-reaction that can cause these cells to go and cause tissue injury in certain organs. So there are several steps for the autoimmune disease to happen, starting with the genes that can predispose to the condition and ending with these self-reactive cells causing the injury at the organs. And as I said, there are so many other factors. So there are genetic factors, there are environmental factors, and importantly also there are hormonal factors. And that explains why some autoimmune conditions like lupus are much, much more likely to occur in women than men. These factors end up producing these different elements of the immune system that could be dysfunctional, as we discussed earlier, and that can cause the tissue damage, whether it's in the kidney, the skin, the lungs, the brain, the heart, or many of the other organs. Autoimmune diseases can be what we call organ-specific or systemic diseases. Luckily, most of them are organ-specific, meaning they only attack one organ in the body. So, for instance, in Graves' disease and Hashimoto's disease, it attacks the thyroid. In the case of type 1 diabetes, it attacks the pancreas and nothing else. In the case of Addison's disease, it attacks the adrenal glands. But there are systemic diseases such as systemic lupus erythematosus, or lupus for short. In this disease, from the name, it can affect multiple organs, the skin, the joints, possibly the kidneys. The good news is that most patients do not have the problem in all of these organs. And in fact, actually, some type of lupus only affects the skin. We call it cutaneous lupus, without affecting any of the other organs. So the big unanswered question about this is, why do these self-reactive cells become self-reactive in the first place? Why does this happen? And there have been so many theories over the years, and so many scientists spending a lot of their time and effort in understanding why this happens. One of the theories that I personally think is very plausible and has gained momentum in the past few years used to be called actually the hygiene theory or hygiene hypothesis. And then later on, other scientists prefer to call it the old friends hypothesis, and I'll explain why. But this is based on specific facts and observations. The first one is that allergic and autoimmune diseases are definitely more common in Western countries than in developing countries. So asthma, type 1 diabetes, multiple sclerosis are much more common in the Western countries than, for instance, in Africa and Asia. And this cannot be explained by genetics alone. We can't say that it is only the genetic makeup of these Western countries that make these conditions more prominent here, because children of families that immigrated to the West develop these allergic and autoimmune conditions at a higher incidence than what it is in their original country. And then the other very important observation is that infections are much less endemic in the Western societies than in the developing countries. And that's largely attributed to the improved quality of drinking water and food and sanitization methods in the Western societies. So can these observations be linked in some way? And the answer is probably yes. So the immune system can be likened a lot of time to a police department, which is tasked with protecting the city that they're in. And when the police department is constantly dealing with threats of different kinds, it functions properly. However, what does happen if all of these threats are gone all of a sudden? Well, some police departments will continue to function normally and find something to do that is constructive with their time. However, it is plausible that some police department might start actually misbehaving, and some of these bored police officers might actually start attacking or accusing innocent people that did not do anything wrong. So that's, in a sense, what happens in autoimmunity when the immune cells start reacting to what should be normal and not really a foreign threat to the body. In other situations, these police officers can actually be super suspicious about everything around them and make a havoc of that. And this is what happens to the immune cells essentially in allergic reactions or allergic conditions. So essentially in this hypothesis, the lack of infections made the immune system more likely to become self-reactive. So the immune system and our genes, what happened is that it evolved over millennia to provide protection against this constant threat from infections, which is the newest term are called the old friends. These actually parasitic infections that used to be very common in the old days were actually providing some element of check and balance with the immune system. And the immune system, with the 20th century becoming the hygiene producing century, could not really adapt quickly because it takes really long time for our genes to evolve and change. And the immune system continued to have these tools to attack the infections, but really didn't know where to use them because there were no infections to be dealt with. And That is a very plausible theory of why we see that much more commonly in the Western societies than in developing countries. However, the reason some people decided not to call it the hygiene theory, because this name might indicate to some that, well, let's reverse that. Let's stop using hygienic methods. And actually, that is not the solution, because especially in a year like this where we have a major pandemic, actually loosening the grip on hygiene would only lead to more infections and more exposure to threats like the COVID infection, but not really reduce the autoimmune or allergic diseases. This theory is more about the understanding of how did this happen in the first place? Why did our immune system as humans become more and more self-reactive? So we'll shift now to talking about lupus and rheumatoid arthritis, and we'll leave some time for questions and answers at the end. Systemic lupus erythematosus, or lupus, is a chronic multi-organ autoimmune disease. It happens when the immune system overreacts to cellular debris. In fact, some lupus experts call this condition a waste management disorder, meaning that the immune system should know how to deal with nuclear debris when cells die, but in lupus patients that unfortunately does not happen, and these nuclear debris become really what trigger the immune system to cause the lupus symptoms. And that actually explains why the UV light is a known trigger for lupus patients. And sun protection is extremely important because UV light can cause more dead skin cells, and that nuclear waste is a trigger for lupus, not just in the skin, but also in other organs of the body. One very important comment I would like to make is that non-specific symptoms such as fatigue, joint pain, muscle pain are far more likely to be due to other reasons than lupus. I see many patients where they suspected lupus by looking up their symptoms, or their doctor suspected it and ordered a blood test called the ANA. But really, lupus is a clinical diagnosis. It's a serious diagnosis that we shouldn't take lightly. And if we don't have really good grounds for the diagnosis, we don't like to call something unless we are really more sure about it. And a positive ANA, that test that I just mentioned, does not equal lupus. And on that ANA, I want to mention that it is a screening test for autoimmune diseases, and it's not specifically for lupus as some people might think. It is positive in 5% of normal individuals, and that percentage actually only increases with older age. So when someone reaches the age of 70 or more, about 25% of people can be false positive for ANA. And that, you can imagine, if 1 out of 4 people are tested and they find that their lupus test is positive, how much anxiety that can cause. So therefore, we cannot rely on this test in the diagnosis, but it is a useful screening test for autoimmune conditions in general. The disease is manageable and it is not life-threatening in the majority of patients. My first few visits with a patient with a new diagnosis of lupus is to try to reassure them that with proper management, 90% of patients with lupus can expect a normal lifespan if the disease is monitored and managed appropriately. Steroids are frequently prescribed and they are excellent to treat flares, but have very significant long-term side effects, so we try to avoid using them on the long time, and we try to use steroid-sparing medications, both old and new, and we have new medications now that help control the condition without having to stay on steroids for the long term. And there are multiple online sources that are less than great, using, saying it mildly, because it can be confusing to patients, very scary, especially when you go on patient blogs. Over the course of my career, I have not seen 2 lupus patients that are identical. So you cannot really use experiences of other patients as pertinent to yours when you are a patient with lupus. So I advise patients to really find sources that are more trustworthy, including the Lupus Foundation, which is an excellent online source for lupus. Finally, let's talk about rheumatoid arthritis in the last few minutes. So rheumatoid arthritis is a chronic systemic autoimmune disease. It's not just a joint disease, it is a systemic disease. It can affect other organs. And it's actually quite common. 1% of American adults have rheumatoid arthritis. So again, 1 out of 100 in a city of, let's say, 2 million, about 20,000 people have rheumatoid arthritis, and that's a lot of people. And like lupus, it is a clinical diagnosis. And like the ANA test we discussed, the rheumatoid factor has its flaws because there are patients who have positive rheumatoid factor and do not have rheumatoid arthritis, or they have negative rheumatoid factor and yet they do have the condition. So these tests are by no means confirming or ruling in or out the condition. We need to put the entire history, physical exam, and other elements together to come up with a diagnosis. The disease is progressive in nature, but can be very slow and deceiving. And I have patients who have tolerated it over time because they didn't want to be treated or they were afraid of treatment. And over time, the damage can be very slow, but cumulative and can be really problematic. And the other thing that many patients with RA don't know is that untreated disease increases the risk of cardiovascular events, including heart attacks and strokes. So even if the patient does not have enough pain to be concerned about the condition, they should be concerned about that disease causing increasing cardiovascular risk. So this is how RA patients usually present, with swelling, not just pain, usually swelling over the joints, typically in the small joints in the hands, in both hands. And our focus when we see a patient like this is obviously to alleviate the pain and the dysfunction that happens from this condition. But my eyes are usually on preventing this from happening, on preventing long-term damage and deformities that can be life-altering for the patients. And yes, we can do that because we have now the tools. We're armed with so many new medications that can actually provide excellent treatment for rheumatoid arthritis in the majority of patients. Fear of medications, which is very real and very reasonable for many patients, because these medications should not, for these patients, because these medications should not be taken lightly. However, should be balanced with the fear of the lack of treatment, which I try to explain to the patients. Chronic steroids are rarely the answer because, as I said, they are associated with very significant long-term side effects. Targeted therapy is now what we do is targeting exactly the part of the immune system that is causing the problem, and we have many options for treatment, but as of now, we don't have a way to know which one will be the best one for that particular patient, which leads us to use the trial and error methods. In the future, we will have more personalized medicine, hopefully helping us to decide which medicines will be the best for patients when we start seeing them. And remission is the objective. We can't make the disease go away, but we can make the symptoms and the cumulative damage so minimal that the patient can hopefully live a very productive and healthy life. Like lupus, a lot of inaccurate information about rheumatoid arthritis online. Dr. Google is really very anxiety driven, in my opinion, and I don't think that it helps a lot of the time. So I caution patients about using Dr. Google for information, and I suggest that they use sources that are very trustworthy, like the Arthritis Foundation. So I would like to end with some general advice about autoimmune diseases. And these should not come as a surprise because they just are common sense. You should ensure a well-balanced diet and have adequate rest. If the brain doesn't rest, the rest of the body will not. You should exercise both musculoskeletal and cardiac conditioning with aerobic and stretching and strengthening activities. as I tell many of my patients, you only exercise the muscles that you want to keep as you get older, because the natural history is for the muscles to actually get weaker over time. You should control other cardiovascular risk factors. All autoimmune conditions can cause inflammation, which increases your risk of cardiovascular disease. So please take care of your blood pressure. Make sure you control it. Control high cholesterol with either diet or medications. Control diabetes, and definitely stop smoking if this is a habit that you still have. You definitely want to find a rheumatologist that you are comfortable with. This is not just a gallbladder that is taken out and it's done. This is not an appendix that is taken out and it's done. It's a long-term treatment that needs to have a very healthy and open conversation and relationship with your rheumatologist. You should arm yourself with knowledge, and attending this webinar is a proof that you are interested in learning more about autoimmune diseases. And finally, if you are affected by autoimmune diseases or you have a family member, I encourage you to be advocates for yourself or your family members to help them. And on that point, advocacy really matters. There are many wonderful organizations that can help people advocate for their conditions and make sure that they're getting the medical care that they need. They have access to medications that can be improving and make a big difference to their lives. So please reach out to these websites and find out how you can advocate for patients with these conditions. I mentioned 2 organizations that are hosting us tonight. I also mentioned the Lupus Foundation, the Arthritis Foundation, North Carolina Rheumatology Association, which is part of actually the coalition of state rheumatology organizations. Both are excellent in advocating for rheumatology patients and patients with autoimmune conditions, and of course the American College of Rheumatology. And with that, I'd like to end and turn it back to Lauren for opening the question and answer session. I hope you enjoyed it.
Thanks, Dr. Kassab. We do have lots of questions coming in right now. The first one, can steroids affect the ANA testing if you're on it, if you're on a steroid?
Not typically. The ANA test, again, if the ANA is an antibody that is produced by the immune cells and can be there for years. And again, it can be in 5% of normal people, so it can be hanging around for years, or it could be simply a reaction to an infection. So some people who have had mononucleosis, for instance, can have a positive ANA for a long time after that without having an autoimmune disease. So being on steroids in particular should not really affect the results of the ANA or the interpretation of the ANA, in my opinion.
Thank you. Where would psoriatic arthritis fit into the information you've shared? Effects to other organs? Is there effect to other organs?
Very good question. So psoriatic arthritis is an arthritic condition that happens in about 1/3 of patients who have psoriasis. And the 2 main organs that this autoimmune disease affect are the skin and the joints. But the other organs that can be affected, as I mentioned, in all autoimmune conditions, is the cardiovascular system. So if you have untreated psoriasis or untreated psoriatic arthritis, you have inflammation in the body, and that can make it more likely for the cholesterol to build up in the blood vessels and cause increased cardiovascular events, whether it is heart attacks, strokes, or other high blood pressure, etc. So fortunately, psoriatic arthritis does not affect the kidneys or the liver or other organs like lupus does, but indirectly it can increase the risk for other problems.
Okay. Have you ever had a patient who was clearly fully joint inflamed but tested negative on an inflammation test?
Oh yes, absolutely. These tests are not specific at all. The inflammation test, remember, it's a blood test. I assume they're referring to the SED rate or the CRP or C-reactive protein. And these tests can be helpful in some patients, but they do not really replace the judgment of the clinician who is evaluating the patient. So if there is actual swelling and some more evidence of inflammation in the joint, it is common for many patients to have normal inflammation markers with inflammation only in a specific area of the body. So that does happen. But at the same time, not all joint pain is due to inflammation as well. So we have to be careful. A lot of patients with osteoarthritis do have pain in their joints, obviously, from the degenerative arthritis or the osteoarthritis. And typically there is very little inflammation in the blood from that, and the inflammation markers are expected to be negative in these situations.
Thank you. Is Behcet's disease diagnosed by symptoms? Could it coexist with SLE?
It is diagnosed by symptoms. There are certain criteria that we follow usually when we evaluate a patient with Behcet's disease. Does it coexist with lupus? I suppose it can, but that would be, in my opinion, somewhat unusual and rare for someone to have two systemic diseases at the same time. And there are many symptoms that overlap, so it becomes really very difficult in this situation to kind of differentiate what is causing what. So that would be a more challenging situation. But theoretically, yes. In reality, I've never had a patient with Behcet who also had lupus.
Can you please explain the difference between a rheumatologist and immunologist or allergist?
Sure. So a rheumatologist is a physician who treats autoimmune conditions that, as I explained in the talk, stem from the immune system doing something abnormal and causing attacks. There are many conditions like that, such as rheumatoid arthritis, lupus, vasculitis, etc. A rheumatologist also can treat non-autoimmune conditions such as osteoporosis, disease of thinning of the bones, osteoarthritis, and some other diseases that can cause muscle and joint pain and some musculoskeletal problems. Musculoskeletal means the muscles, the bones, and the joints. An allergist or an immunologist is a different specialist who specializes in the more of the allergic type of dysfunction of the immune system. If you remember, in the middle of the talk, we talked about the different kinds of immune dysfunction. So the first type was one that the immune system causes an allergic reaction rather than an autoimmune reaction. So an allergist is someone who is more versed and more trained in treating patients who have an allergic problem. They also deal with immunodeficiencies where the immune system may be lacking certain elements that are essential in protecting against infections or protecting against other threats, and the immunologist is usually the one who assess that. There is an overlap between what the rheumatologist and the immunologist do, but in general, the conditions that are treated by immunologists are different than the conditions that are typically treated by a rheumatologist.
Thank you. If you have a negative ANA test and are still clinically meet symptoms, is it still possible to have an autoimmune disorder?
Yes, but it becomes less likely. And for instance, lupus is ANA negative in less than 2% of the time. So it is possible, but it's extremely unlikely. And in these situations, we have to be very cautious and have really very good grounds to make the diagnosis. So for instance, if we have a patient who has a biopsy of their kidneys showing lupus nephritis or lupus affecting the kidney, then even if the ANA is negative, I think we have very good grounds to diagnose this patient with lupus. Or if they have a skin rash that is very typical of lupus and a biopsy of that rash also prove that, then we will diagnose this with lupus even if the ANA is negative. However, if the symptoms are non-specific, and non-specific means they are not really, they can happen in lupus, but they do not point specifically to lupus, then it becomes really difficult to diagnose with lupus if the ANA is negative. And in terms of other autoimmune conditions, certainly, I mean, there are many conditions that have a much lower likelihood of a positive ANA. For instance, vasculitis, which is, as I mentioned, it's a group of conditions that affect the blood vessels. There is a different test for that called ANCA or ANCA, and the ANA is typically negative in these conditions. So yes, you can have an autoimmune condition with a negative ANA.
Thank you, Dr. Kassab. How do you feel about biologics in treating Behcets disease?
They are very useful in the appropriate clinical setting. So there are times when you go through the first line of treatment, which are the traditional medications, and you still have symptoms. And in these situations, there are certain medications that are more targeted towards a specific element in the immune system that can be very helpful. So yes, I support that in the right clinical setting.
Should immune suppressants be paused for taking the COVID-19 vaccine?
So the American College of Rheumatology just came out with recommendation or guidance about that. And it depends on the medication, but most medications, the answer is no, which is a relief to hear for a lot of the patients who depend on these medications to control their condition. There are a few medications that do require either altering or changing the schedule of treatment. And I would definitely advise the patient to consult with their doctor so that they understand what the recommendation about their particular medication. But for many of the medications, this guidance just came out about 2 weeks ago, and it's you can find it actually on the American College of Rheumatology website, and it does list all the different medications and what the recommendation is. But every patient is different, so I definitely recommend that you check with your rheumatologist or your provider before you make any decisions about your medications.
Always a good thing to ask your provider that oversees your healthcare. Does my having osteo and RA make my degenerative disc disease progress faster?
Can you repeat the first part?
Does my having osteo and RA make my degenerative disc disease progress faster?
Yes. The short answer is yes. Osteoarthritis can cause degenerative disc disease, but in patients who have also rheumatoid arthritis, this is more fuel to the fire, if you will. It can cause more degeneration of the disc, of the joints around the spine, especially if the rheumatoid arthritis is untreated. However, if the rheumatoid arthritis is adequately treated, it should not be a factor in the progression of the degenerative disc disease, because degenerative disc disease and spinal arthritis or osteoarthritis can have a mind of its own, can be progressive regardless of what's going on. So if the rheumatoid arthritis is untreated, definitely can be contributing, but if it is under good control, then it probably is not.
In Behcets with normal blood work panel, can a rheumatologist help with joint and muscle pain?
Depends. Sometimes we are able to help. Sometimes there are things that are very challenging and difficult to manage. A lot of patients with autoimmune conditions, including Behcet, can have different sources of the pain. and it's really figuring out what the source of the pain is. And some of the pain is much more amenable to treatment than others. So I definitely would recommend consulting with the rheumatologist and trying to work with them to figure out how they can help in alleviating the symptoms.
Okay, have time for a few more questions. Could reoccurring GI bleeding since early childhood be symptomatic of an autoimmune condition?
I'm afraid I'm not going to be able to really answer this question without knowing more details. So this is a question that should be directed at the care provider. There are so many follow-up questions that would follow this question for me to answer it more, intelligently. So I apologize. I'm not going to be able to give advice on this.
Okay. Going back to the hygiene theory, would you also suggest there's a possibility of genetically modified foods that we have in the Western world contributing to an increase in autoimmune diseases?
I suppose that could be a problem, because any substances that are not studied, including genetically modified food, can be considered foreign to the immune system and cause problems that we are unaware of. I don't think there is any proof to that, but I think staying away from genetically modified foods is probably wise, and staying with more natural occurring foods. And this is a very difficult subject, because what is considered genetically modified versus not? I mean, there are so many classifications and so many theories online, but I suggest taking a very reasonable, mainstream approach to this, and not really go to the extremes. Because I've talked to patients and other people who go to the extreme in their diets and become very restrictive because of their concerns. And I think there's no specific proof for us to warrant going to those extremes. So yes, I think staying away from what looks unhealthy, what looks vastly modified, but staying within the mainstream and not go to the extremes of diets is my recommendation.
Okay. Thank you, Dr. Kassab. I got one more question here. I'm sure everybody's dying to hear about this specific one. Very briefly, you don't have to go in a lot of detail. What is the current research, if there is any, for autoimmune patients and the current COVID vaccines available now?
Yes. So there is always, like everything, there is the good and the bad, right? The bad news is it has not been studied. So all the trials that were done for the major vaccines that have been authorized by the FDA have not included patients specifically who have autoimmune conditions. However, the good is that by the virtue of immunizing so many people across the globe now, in many countries, since December and on, many patients with autoimmune diseases have received the vaccine already, and there are no reports whatsoever, any early reports of any problems with the COVID vaccine. And in fact, there are many patients who are taking medications, as someone asked earlier, who are that are suppressive of the immune system and took the vaccine, and it's been more than a couple of months now and had no effect on the treatment, on the underlying condition, or on the vaccine itself. So far, no alarming signs or symptoms or anything to be really very concerned about. But obviously, it's a risk that someone has to be comfortable with taking, and I am recommending it to all of my patients with autoimmune diseases, because the risk of COVID and being one of the unlucky people who end up in the hospital on a ventilator is much higher, or even giving it to someone else in the household who might end up on a ventilator, is much higher than the possibility of this vaccine causing a problem for the patient themselves. We recommend all sorts of other vaccines, shingles, flu vaccine, pneumonia vaccine to patients with autoimmune conditions. So this particular vaccine should not be any different, but with the caveat that it has not been studied. So I always mention that to everyone who asks.
Thank you. Thank you, Dr. Kassab, for being with us tonight and volunteering your time to educate our community. And thank you to our audience for listening to today's webinar. Don't forget to tune in for our next webinar on April the 6th for multiple sclerosis and specialty pharmacies, an overview of care and treatment. We'd also, again, like to thank the American Behcets Disease Association for their partnership for tonight's webinar as well. And also, please take a few moments to fill out our survey. It's 4 questions, and after the conclusion of today's webinar to help us better serve our community. And please visit our website for more information and resources at www.godoaida.org. This is Lauren Dunlap with Advocacy and Awareness for Immune Disorders Association, and we hope you have a restful evening. Thank you so much for joining us. Have a great night.